Chronic leg ulcer can be due to many reasons. The two relatively common reasons behind ulceration of legs would be deficiency of circulation, including venous or arterial system. Certain risk factors for venous insufficiency, including poor mobilities, for example, after big operations such as knee replacement, hip replacement, obesities, especially those with a lot of fat around their waist area, those people with heart failure, certain medication, especially calcium channel blocker such as amlodipine, and past history of deep vein thrombosis. Patients with venous ulcer might have other features. For example, the lower leg, including feet and ankle area, might be very swollen with discoloration. They feel more relief by raising their legs. In contrast, when they're standing on their feet for a long time or crossing their legs, especially when they are on long haul flight, the symptoms might become much worse. In arterial ulcer, in contrast, we have very pale and cold toes, feet, ankle. In chronic and long-term condition, we have discoloration and nail changes. Some patients with venous ulcer, they might have a skin becomes very firm and stiff like leather. That's a condition we call lipodermatosclerosis. Compared to venous ulcer, in arterial insufficiency, we have very cold and pale toes, feet, and sometimes lower leg. These patients might have other underlying conditions such as diabetes, high blood pressure, and other features with ischemic vessels such as a stroke or history of ischemic heart disease. Majority of them are smokers, which can trigger the process of blockage of arteries on their lower extremities. The pulses on their feet are very weak. Also, they found it more painful on exercise and especially lifting their legs. In both groups, the symptoms can change and the appearance might look very different due to other complications. The commonest one is infection. So especially in venous ulcer, there is a higher risk of superinfection. Bacterial infection are the commonest one, and in long term they might make a barrier called biofilm, and this barrier doesn't let any treatment, especially topicals, to work on the area. And unless the barrier is removed by surgery or debridement, the treatment will not be satisfactory. In my clinic, the appropriate protocol would be to remove the infected area. We do it usually after application of numbing cream, and then we start appropriate dressing for controlling the infection. And in the meantime, we treat the area with courses of photodynamic therapy. Very rarely, we might need other modalities such as exosome infusion to help and speed up the healing. Meantime, we ask other colleagues in vascular team to assess the arteries and veins, and in case the arteries are intact, they use compression dressing or sometimes compression stocking So this lovely lady came to us around August with a lot of nasty looking ulcers on both lower legs. So it was with thick layer of biofilm. Because of the infection, it was very painful. So I couldn't even touch the normal skin, but now it's absolutely fine. Everything healed very well. Are you happy with the outcome?
Oh, ever so. Ever so. Ever so. Over the moon, really.
Excellent, excellent,
Yeah,
excellent.
over the moon.
Excellent. Brilliant. And how is the outcome with the vascular team?
Got
Yeah.
the all clear.
All clear.
Yeah.
Okay, fantastic.
Mr. Simon was really good.
Fantastic.
Yeah.
Excellent.